I actually wanted to start with a little thought experiment, and that was to ask you to imagine that a woman has come into a doctor's office complaining of severe lower back pain. She's 39 years old. She came as a refugee from Sudan 8 months ago, and she arrives in the office with her 7-year-old daughter. What are some of the issues that you would want to think about that would be particular to considering how this woman's medical history would be taken, or how the medical exam might take place? So just take a second to imagine this woman and imagine what some of those issues might be. And then secondly, imagine that the physicians decide that there's no evidence of an acute injury, but that she would benefit from psychotherapy. Are there any particular issues that might arise regarding this referral? Are there any barriers that might arise as a result of this referral, or in her ability to actually act on this referral? The reason I'm asking you to think about this is I'm actually asking you to think about how to use this thing. Okay, I've just turned us off. While we're thinking about this, thank you.
Everything, so that's forward and that's back.
Okay.
And that's laser pointer, so don't touch that.
Don't touch that one. Don't touch that one. The reason I'm asking you to think about this is I'm asking you to think about what might be unique or what might be more challenging for women who have a refugee background relative to men who have a refugee background, or relative to women who might have a different kind of migratory background. And the issues that we think we have to address are grounded in our assumptions about what is different on the basis of gender or what is different on the basis of migration pathway. And we know that there are going to be some differences between women and men as a result of biology, but we also know that there are going to be many differences as a result of social roles. And those social roles can limit women's access to health care because of pre-migratory roles. For example, we find that there are far fewer women who are refugees who drive than there are men. And as a result, for those who are living in the suburbs, accessing health care or any other service can be really challenging. And we know that current roles often involve childcare responsibilities, and as a result, women can find childcare responsibilities to be a barrier in being able to attend healthcare services. In terms of thinking about what the differences might be on the basis of migratory status, both women and men are exposed to a number of hardships that have already been discussed. Thank you, Chris Greenaway. I can skip most of this. One of the things that is remarkable about that migration pathway is that it is also associated with very high levels of not only physiological but also social risk. So recent research that was done with migrants crossing Africa found that depending on which pathway they were taking, somewhere between 1/3 and 2/3 had been exposed to some form of violence, assault, robbery, kidnapping, and sexual assault. And while we know that the conditions in situations of asylum are quite poor in terms of poor sanitation, access to clean water and food, and access to anything more than primary health care, we also know that there are elevated risks of gender-based violence. So there are particular risks, even within these pathways, for women who are coming through the refugee migration pathway. Just to give you an example of how these things come together, if we look at a recent scoping review of perinatal mental health disorders that looked at women in the United States, Australia, and Canada, they found that risks of depression in particular, antenatal and postnatal depression, were elevated among migrant women relative to non-migrant women in all 3 countries. But only in Canada were those risks higher for refugee than for immigrant women. We tend to assume that the differences between migrants who come through an immigrant pathway and a refugee pathway are the exposure to trauma that they've had prior to coming. But if that were true, then we would expect to see elevated risk among all 3 of these groups. So it can't just be attributable to pre-migration trauma that we're seeing these differences. And that brings us to what some of the other determinants are of both mental health, but also health and healthcare access more generally, which are the social determinants. In this study and in other studies on depression, we see that one of the predictors, among the predictors, are social support, marital disharmony, socioeconomic difficulty, visible minority status, and proficiency in the host language. And that these are all factors that can be elevated for women with a refugee background. And I want to focus particularly on language. And the reason I want to focus on language is that in the Canadian context, language is actually one of the biggest differences we see as a function of migration pathway. Because of the way we choose immigrants coming into Canada, they either come in through economic migration or family class migration or business migration, language is one of the conditions on which they are chosen. So according to Statistics Canada, only 10% of immigrants arriving in Canada in 2016 spoke neither English or French on arrival. Refugees, on the other hand, enter Canada on the basis of humanitarian need. Language is not a requirement. And we see that between 65 to 75% of refugees arrive in Canada speaking neither English nor French. This is compounded by the relationship between education and language. These are data drawn from a study that Haida is a co-principal investigator on. It is the Syrian Refugee Integration and Long-Term Health Study in Canada, and we're following about 1,900 Syrian refugees in 3 provinces across Canada. And one of the things that had come out very clearly in this study is that there's a strong relationship between being able to speak either English or French on arrival and educational background, and that difference, the relationship between education and language, is stronger for women than it is for men. Once you get to higher levels of education, those differences disappear. But for those who have very low levels of education, they are confronted with the challenge of speaking neither English nor French, and also having limited literacy in their first language, which would make learning the language more difficult, but will also have implications for their ability to navigate healthcare. The longitudinal study of immigrants in Canada, which has been discussed earlier today by Chris Greenaway, had questions asking people to rate their self-perceived health, but also to rate their language ability. And as Chris mentioned, self-rated health does decrease over time, but you will notice that self-rated health decreases over time more strongly, or with a greater slope, for people with lower English language ability or French language ability than those whose language ability is stronger, and that increase is greater for women than it is for men. So what is it that's happening with language that makes it such a risk factor for health? One of the obvious links is that it has a direct impact on health because of its impact on healthcare access. So we know that people who have limited language ability also have challenges in identifying where they can access healthcare, navigating the healthcare system once they are able to access it. They have a harder time advocating for their needs, so they have more unmet health needs. They have a harder time advocating for their health preferences, and if you're not getting the healthcare that you prefer, you're also less likely to follow up on recommendations, and you may be less likely to follow up on treatment and medication protocols. Finally, even when we do provide interpreters, interpretation is often problematic. People can be uncomfortable talking about health conditions in front of strangers who are professional interpreters. They may prefer to have family members as interpreters, but this is problematic because family members are not professional interpreters. They may misinterpret medical information, and you may have to share information that you shouldn't be sharing in front of family members, such as a previous history of sexual trauma when your 7-year-old child is the person doing the interpreting for you. It also has an indirect impact on health through the social determinants. We know that language is one of the strongest determinants of social isolation, and that social isolation is a major determinant of health. Likewise, language is a very strong predictor of one's ability to access a good job, decent employment, which is also a predictor of poverty, which again is a determinant of health, but also a determinant of social isolation. When looking at the kinds of barriers that both men and women report in terms of accessing services, again, we're going to refer back to the SYRIA.LTH study. One of them is transportation. The distance that people have to travel and the means that they're going to get there is a barrier to accessing health services. Likewise, the amount of time that it takes. Particularly if you have precarious employment, it is very difficult to get time off of work, and so we see people in precarious employment not accessing health services because they cannot. Finding childcare is particularly a problem for women, so this is a place where you actually see a gender difference come out quite strongly. The costs, and this is hearkening back to the fact that in our studies, we're finding that people are still being refused acceptance of IFH. So even though they're covered with insurance for the services they're seeking, they cannot find healthcare providers who will accept IFH. But the big one continues to be language. Other social barriers that have come up in our research and in other people's studies include social support. Social support is known to promote healthcare access for all populations, but refugee women in particular tend to be socially isolated and have lower levels of social support because the refugee migration process ruptures social relationships. Families are scattered and people are left behind. A lack of culturally appropriate care, and in the case of women, that also means, in some cases, a preference for female healthcare providers. And finally, experiencing discrimination and facing stereotypes among healthcare providers. And I want to now come back to the Sudanese woman that I was talking to, Fahima, and I want you to think about what you assumed about the woman who was sitting in that office, and whether the characteristics you assumed that she had resembled the characteristics of the woman that this story was based on. This is Fahima Hashim. She was the director of the Salma Women Resource Center. She has a master's degree. She was a known activist around women's rights in Sudan until she was eventually had her center shut down and came to Canada as a refugee. So I just want to remind us that one of the barriers that women face is the assumption that refugee women, and particularly African refugee women, are passive, lack agency, are helpless, and that these also act as barriers to the kinds of resources women need in order to achieve good health. Thank you.